Right, here we are again. Going to smash some more gastro questions. A 21-year-old woman complains of intermittent diarrhea and constipation. She has bloating relief by defecation, gains relief on buscopan, denies weight loss, no relevant family history. Celiac disease screening was negative, and both FBC and CRP were normal. Diagnosed with IBS, she's been given dietary advice and antispasmodics. Disagreeing with her diagnosis, she requests further tests. Okay, what do we need to do? Sounds like it's doing okay, but fecal occult blood test, an option. Repeat FBC, they're all normal. Reassure that testing further is not required. Take steroids, take azathioprine. I don't think we need to medicate anything. There isn't anything shown for that. Do we need to look again? When were these tests done? Presumably they were recently. Fecal occult blood test, it feels like she's 21 with IBS and she gets symptomatic relief with buscopan. It does sound very IBS-y. It doesn't seem like there's any red flag symptoms, but they aren't really talking about intermittent diarrhea and constipation. I don't know at what point we would think about doing some endoscopy here. That's not an option. I really don't know what we're going to have to do for these tests. I'm pretty inclined not to do much more. She disagrees. I don't think it's going to be a blood test. When they did the last blood test, they said it was all fine. Alright, fine. Colorectal cancer via fecal blood testing is not appropriate under the age of 60. These were the vibes. Let the vibes continue. We now have a 61-year-old man admitted to the hospital with severe abdominal pain, typically worse following a meal. He admits he regularly drinks 25 units of alcohol per week for the last 30 years, and he's been diagnosed with type 2 diabetes mellitus. CT scan shows a calcified pancreas. Given the likely diagnosis, which of the following tests can be used to assess his organ's exocrine function? I think the signs of the calcification of the pancreas is that it's a chronic pancreatitis. Sounds like it's ongoing for a long time. He's a heavy drinker. Doesn't sound like an acute pancreatitis. It sounds some sort of colicky pain, but that is that calcification of pancreas. So this is probably a chronic pancreatitis. So I don't think we need to worry about the amylase and lipase, which would be up in acute pancreatitis. Fecal calprotectin is not going to be the one, because that's used in IBD. And fecal elastase, I'm pretty sure, would be the ticket. I don't know about serum calcium. Are we just going for that because of the calcification? Don't know. But the fecal elastase will actually show, if anything, the exocrine function. We'll show the exocrine function because, if anything, it's going to be the issues with malabsorption rather than the endocrine function, which is obviously to do with diabetes. Alright, let's see. Easy. Okay. We were able to whittle that one down. We didn't fall in the traps of the amylase and lipase for a chronic pancreatitis. Alright, I think we're happy with that. 9-year-old boy presents to ED, 1-day history, intermittent diarrhea, central abdominal pain, right iliac fossa. Alright, appendicitis. That's all we know. On examination, he is pyrexial, guarding right iliac fossa. Get the pancreas out. Get the pancreas out. Get the appendix out. Select the most appropriate investigation of the list below. Adults, you do a CT. Children, you do an ultrasound. Barn door. Don't think I've seen an MRI done for it. I think if you're that concerned, you will just do an exploratory look. Yeah, a diagnostic lap. You would just take it out. Anyway, next we have a 54-year-old male presents ED with 3-day history of severe upper right quadrant pain, with 2-month history of intermittent ache in the right upper quadrant. His basic observations include a heart rate of 115, so he's a bit tacky. Resp rate 28. Okay. BP is pretty low, 90/55, and is he septic? Why is he? These are all not good signs. So he's febrile, hypotensive, tachycardic, tachypnea, desaturating, and his medical history includes hypertension and type 2 diabetes. Okay, well, we're going to look at some bloods. White cells are a little bit up, amylase is pretty up. Right, so this man's pretty unwell. We know that the bilirubin's up, ALP is quite highly up. ALT and amylase are both a bit up. ED, right upper quadrant pain. Does he have jaundice? Is this any jaundice on here? No. Okay. He's got high bilirubin. So is this going to be Charcot's? Is it going to be Charcot's triad? It seems a bit intense to be cholecystitis. Maybe that's what he was having before. This sounds like ascending cholangitis. He's got a fever, right upper quadrant pain, and really deranged LFTs. He doesn't talk about having jaundice on here, but with that raised bilirubin, I'm thinking that's what they're going for. Charcot's cholangitis triad. Yeah, if he didn't actually specifically say jaundice, but anyway, fine. Easy. Ones we've got in the book. Oh, we love these short ones. Right. A 34-year-old male, central abdo pain radiating through the back and vomiting. Following results, medication is most likely responsible. This isn't going in the vein of the get smashed mnemonic that everyone learns. I'm pretty sure, I don't know about phenytoin. I feel like sodium valproate does cause some of these issues. Sumatriptan, nope. Pizotafone, never heard of it. Okay. Oh yeah, I wasn't sure about the phenytoin. Hey, here's the get smashed acronym. We got some of the drugs on here. Yeah, azathioprine. I just feel like sodium valproate does so many things. Okay, next. Another short. Oh, it's the exact same question. Sodium valproate. Alright, not bad. Next question. 31-year-old man returns for a review. Diagnosed with anal fissure 7 weeks ago. Has tried dietary modification, laxatives, and topical anesthetic with little benefit. Okay, so he's got an anal fissure. What's the next best step? I remember people coming in having had this treatment when I was on GenSurg. I'm pretty sure it's topical GTN. I think so. That is the option. Alright, I feel like from memory that's what it was. And that's what makes most sense. Alright, brilliant. He's already tried laxatives. Wonderful. Let's see how the rest of these go. A 51-year-old homeless man has been brought into the ED with a collapse and sudden onset of left-sided paresis and facial droop. We're worried about him having a stroke. CT scan shows large ICH. You suspect coagulopathy is the cause of this spontaneous bleed. You are unable to ascertain the past medical history. Clotting products prolonged. Factor 8 is high. Factor 8 is high. All these other factors are low. Von Willebrand factor is high. What's the most likely cause for this coagulopathy? Okay, if haemophilia A and von Willebrand disease, we'd expect those to be deficient, but they're high. So that doesn't make sense. Haemophilia A would be 8, B would be 9, which is low. Okay. Got DIC. No, he's not presenting like DIC. He's a homeless man. Is there further clotting factors downstream that I'm thinking about? Is this generalized liver failure? I reckon this is generalized liver failure. Liver failure, all clotting factors are low except for factor 8, which is supernormal. Okay, and yep, they said the same things for haemophilia A and von Willebrand disease. Perfect. Fine. Next up, a nice short question. 43-year-old lady recovering following a live donor-related renal transplant. She has significant abdo pain. She's just had a renal transplant. I don't know much about renal transplants. I've been worried about morphine if the EGFR is below 30. Is it going to be diclofenac for NSAIDs? Maybe NSAIDs are contraindicated following a kidney transplant. I think paracetamol and everything else should be fine. NSAIDs may be nephrotoxic and therefore are usually avoided in patients who've undergone renal transplants. Okay, excellent. Fine. Those are pretty straightforward. We've got a lucky number 10. Last question. Hopefully we can get a nice little 10 for 10. You are asked to review a 63-year-old woman, new onset confusion. Her past medical history is significant for alcoholic cirrhosis of the liver. On exam, you note that the patient is not orientated to time, place, and person. Okay, she's got alcoholic cirrhosis. She's disorientated. She has asterixis and several cholangioectasias on her trunk. Most probable diagnosis. So she's got liver failure. I know that when they get these, it's for the confusion. I know that they give lactulose in order to reduce the urea, because these patients get hyperuricemia. and that can cause confusion and cerebral edema. So you give them some Lactiose. All right, that's an easy set of questions. Let's jump in, Cock.